elderly people who are like above 70 or 80, open heart surgery or a bypass surgery. I meant to say, are there any recent advances to compensate this open heart surgery?
Open heart surgeries, so many restrictions.
Cardiac surgeries or neurosurgeries are reachable to all the common people who can't afford.
Material cost will be high. So most of the materials are manufactured in US. You can see we have a camera where we can see inside the heart, can see the inside the arteries. All this comes with a cost.
Halter device also?
Halter device, ECG monitoring device, anywhere, even from the remote places,
Okay.
you can monitor it. It's all on the cloud.
Talking a lot about the salt, its impact on cardiac.
Body needs to some extent. Anything excessive, it will store somewhere.
You must have seen youngsters also going through this cardiac issue. So what are your views on it?
So youngsters especially, I see a lot of, generally their heart doesn't tolerate. We age, our body gets adjusted. Cotin is one bad thing. It's an enemy for the vessel.
So, cardiologist and interventional cardiologist. What's the difference?
So cardiology is a vast subject. So cardiology means related to the heart. So interventional is the term where they started doing interventions from somewhere around 1980s, 1960s. So they tried to resolve some problems where you can't treat with the medicine. So that's where this interventional cardiology started. So back then, if the cardiology, the work of cardiology or the study of cardiology, it started all to have the knowledge about the heart itself. So when you want to treat the cardiac related issues, initially you start with medications. Then when you are not able to treat at some extent or you are diagnosing it lately, so what you want to do? So you need to resolve it and then you need to give the treatment.
Okay.
So the newer era, like diagnostic things where it came into the picture. Now if you see in the last 20-30 years, you can see there are a lot of diagnostic tools which came into this world. So which can diagnose there is any minute block or minute things in the heart. So how can we intervene that? So that is called interventional cardiology.
Okay. So if that's the case, like what are the first line treatment procedures this so-called interventional cardiologist will handle?
So we'll say like diagnostic procedures and therapeutic procedures.
Like?
Diagnostic in the sense we can, like you can say coronary angiogram or any peripheral. We treat as a cardiovascular. So
Okay.
wherever the blood goes, we goes there. Now there are so many sub branches. So if a angiogram diagnostic thing goes to we check the heart, then it's called coronary angiogram. If we check the brain, we call it carotid angiogram. So multiple things. So coronary angiogram is one thing where we check if there are any blockages which supplies to the heart. That is coronary angiogram. We do CAT studies, we do imaging studies, we do multiple things in this diagnostic era. So that is where the initiation of the interventional cardiology starts.
So if that's the case, like which department of cardiology is gonna deal with open heart surgeries?
So interventional cardiology is completely a different set of medicine in cardio intervention. So if you after MBBS, people tries to do surgical interventions. So like they go to general surgery and general medicine, where the subspecialty comes as a cardiology, and then we train for interventional cardiology. It's actually a fellowship or imbibed with the cardiology DM course itself. So these people who does general medicine and cardiology, they will be trained with interventions, and then they do fellowships, and then they go for interventional cardiology, where
Okay.
that doesn't open the heart completely. Without opening, they do the diagnostic procedures and the treatment. That is the art of
Like kind
interventional
of
cardiology.
minimally invasive procedure.
Yeah. So if you say surgical interventions, so people who does general surgery and then they take cardiothoracic surgery and then they do the surgeries. So where we diagnose and we treat if we are not able to treat that particular one without intervention, or if they need an open heart or bypass surgery where we can't intervene with our interventions. So then the surgeon comes into the picture.
So let's say in recent days, like I don't say recent days, apparently like currently elderly people who are like above 70 or 80 who are supposed to get an open heart surgery or a bypass surgery. Are there any alternative procedures to avoid this huge, scary surgeries and get for the comfortable procedures?
So it can't
I meant
turn.
to say, are there any recent advances to compensate this open heart surgeries?
Yeah. So there is a lot of recent advances which came into the picture, like last 20 years, we can say. Open heart surgeries, there are so many restrictions in the open heart surgery. The lung to be proper, the brain to be proper. If there are any other major comorbid conditions, and age itself is a high risk for any open heart surgery, it's a per se. So now we can talk about something like a non-surgical, we say transcatheter interventions, like any valvular surgeries where normally you have to open the heart to change the valve or repair the valve. Now we can do it without opening the heart. We can just go through the artery, aorta, and intervene the valves. We can repair the valves. We can replace the valves, and we can even close the holes with the devices. So these are the latest advances where we can do if the patient is not fit for the surgery or very high risk for the surgery.
High risk in the sense, what could be the risk factors?
So there are multiple risk factors. Generally, we tend to see when we are sending the patient for a surgery. Like if the patient had any history of recurrent strokes or a major stroke, that's a very high risk. Or if the patient is having any underlying lung issue, you can see now we have seen the COVID era.
Yeah.
Post-COVID, a lot of lungs were damaged. So it's very tough to go through the surgical part with an any ventilatory support, long-term support, and the lungs may not resolve while coming out. So these are the high-risk procedures.
So, as you've mentioned about the COVID era, there's a lot of gossip being spread around that COVID vaccinations are the prime cause for cardiac issues. Is it so?
So we can't definitely say that's the cause for it, but there are very few evidences saying that COVID.
Yeah, I mean to say it's partially contributing to the cardiac issues.
Yeah, COVID is causing in particular some area of people, but there is no direct evidence saying that yes, COVID itself is causing it. But definitely, with the experience, I can say, seeing the patients before COVID and after COVID, there is much rampant increase in the cardiovascular risk in the younger patients compared to the older patients. Before we used to see much of older patients, but now we are seeing much of younger patients compared to the before pre-COVID era.
So recently, I came across a few of your articles on social media actually, like treating a elderly woman with some advanced valve procedures. Can we have a little chat about that?
So she's an elderly, she's almost 90-year-old female,
90, yeah.
90-year-old female. She has this valve leakage. It's called mitral valve regurgitation. It's a severe valve leakage, and she's a frail lady, and she's comes under high risk intervention. I mean, like open heart surgery. She needs an open heart surgery and the valve replacement. So she's having a lung issue where it's very bad, and so she'll be under the high risk category. So they went over and they came. Recently, we started this procedure. The first case when I started back some 4 years back. So that patient is around around 88, 90 years, where he was almost bedridden for 6 months. He went all over all the hospitals, high risks procedure. So no one wants to touch the patient because high mortality risk. So this transcatheter mitral valve repair with mitra clip. So that's one procedure where it's there in Western world. Now we have in Apollo, we have this research program going on with the trial program only at Apollo Chennai. So then we took the permissions and all, and he was there in the hospital almost like 2-3 weeks for this procedure. And then we took all the permissions, and with the support of Dr. Saibal Kar, who is the godfather of this mitra clip from US, LA. So with his backup support, we did the first procedure for him, where now he comes by walk. So even this lady has the similar thing like him. She is having very bad lung. So we perform this procedure, and it's a very minimal like the length of stay will be like 2 to 3 days, and the patient will be able to walk the very next day. It's a short procedure, but it's a you need to have the timely understanding of the valve, whether the clip will
Regular monitoring is like
and
mandatory.
the like pre assessment is very important for this
Okay.
procedure. So this is a newer technology. Like recently, I did for another patient just 2 days back. So there is an Indian company called Merrill. So they have introduced this clip. Just this, I did the first case to two
Wow.
days back. So that was the commercial launch of this clip, the same one like how this clip about company is doing that. So the similar company, Indian company, have manufactured it, so we used it on a patient. So it's evolving. Even the Indian companies, they started manufacturing this, so the cost cutting will be there. So we are hoping that at least
So
some amount of
yeah.
like.
See, basically, when it comes to cardiac surgeries or neurosurgeries, most of the people they have the fear of finances, irrespective of insurance and all. They still have that fear of finance. So maybe this is like reachable to all the common people who can't afford for.
So the problem with this is, as an interventional cardiologist and structural procedures, the material cost will be high. So most of the materials are manufactured in US.
Yeah,
Everyone wants an imported one. No one
true.
wants an Indian
Not
made.
really. You can't say that.
No, I mean like
Okay,
so
let's say a few.
when someone wants, it's a life thing. Okay, and when someone wants a higher standard ones, the cost comes into the picture.
Yeah.
You can see we have a camera where we can see inside the heart.
Oh, really?
Yeah, and it costs. And we can see the inside the arteries imaging, and we have lithotripsy balloons, we have calcium cutting tools. All this comes with a cost. So that's the problem where we are also facing, like common people, how to get to the common people. That's very tough now. If Indian manufacturers come forward and start doing this to some extent, there will be a lot of change in the treatment, especially in the cardiac place.
So, in such minimally invasive procedures, are there any like wide range of post procedure precautions to be taken or like handled?
So these transcatheter procedures, intra procedure is the main component. Post procedure, if you take aortic valve, we say TAVR. So post aortic valve implantation. So initially we need to look for the heart rate, if any complete heart blocks happens and all. So initial 24 to 48 hours monitoring is important. So most of the people will go away with a normal thing, and they don't need any extra evaluation. The maximum they need some BP calculations and some antiplatelets and heart rate monitoring devices, which we have handy nowadays. We get like everywhere, so we can attach that and do monitoring from the home also.
Oh, so is it something like a halter device or so?
Yeah, Holter device, ECG monitoring device, where you can do it from anywhere, even from the remote places. You
Okay.
can monitor it. It's all on the cloud.
So, do you think like I've seen in a couple of your previous podcasts and interviews talking a lot about the salt and its impact on cardiac health? Is it so?
Yeah, everything should be on par. Like body needs to some extent. Anything excessive, it will store somewhere. So the salt is also same. Everyone feels the salt which we mix in the
Yeah,
like.
people say that's the culprit of
Yeah,
everything.
so no one knows that where exactly the salt lies. There are so many places where the salt lies in our day to day, which we have on a daily basis. Everyone have pickle, everyone has sauce, everyone has ketchup. All these things, breads, everything will have salt. So the restriction, like you shouldn't think like every day I eat bread,
So
or
we
every
can't
day
blame on
you
salt.
can't blame. Every day I eat butter, it has salt. So you can't
If
blame.
that's the case, I really want to understand, is there any correlation between the renal health and the cardiac health impacting each other?
Definitely. So renal cardiac is always correlated, especially the BP monitoring one. Mainly,
Oh,
it will be
by
regulated.
salt playing a key role in it?
Yeah, definitely,
Okay.
definitely. So renal, if you see the renal, it filters the salts, it filters the potassium, it filters. So it's all the tubules which in the kidney itself will have all this effect. So if there is any major variation in those things, so you will see it's a regulatory mechanism. So the renal regulatory mechanism is one thing which controls your heart, which controls your BP. So salt plays a role.
So, as you mentioned, BP. Let's say we were talking about advanced valvular procedures and all. So will BP is gonna have any impact on it, like any failure of procedures due to, of course, the BP can be controlled. It's under your control based on medications and all. But once the patient is discharged, how
Yeah.
can the management be handled?
So that's why we always monitor the BP when the patient is inpatient. We try to adjust the medications as much as possible. We don't want to give very high doses or low doses. We don't want the BP to shoot up very high, because post procedure there will be some complications.
Because what I meant to ask is like, see, let's say BP plays a key role because you are replacing the valves, right? So obviously they are directly proportional to hook or break, right? So
Yes.
in such cases,
So we are changing the hemodynamics. If you're talking about replacing the valves or repairing the valves, so everything works on hemodynamics.
you
So
mean to say adding blood thinners?
not blood thinners. So if we are talking about the valve, if the valve got damaged, so it means
Okay.
the heart strains to pump the blood,
Okay.
okay, from the valve. So when we are replacing the valve, we are replacing it with a fresh valve, a new
Okay.
valve. So the heart doesn't strain. So the BP or the heart rate, whatever is there before, will be like minimally variation will be there after the procedure. So that's why we want to monitor at least 24 to 48 hours after the procedure and adjust the medication. Some people the BP will come down, some people the BP will go up. So that's when we
Never know
monitor the
if they
initial
double
phase.
dose of medication or skip the medication in
Yeah,
such
that's why we
cases.
always ask them to monitor the heart rate and BP at least. So
Okay.
that's the basic things we ask them to do it at home.
So are there any like random complications after this valve replacements,
Random
which were
com
like absolutely unpredictable?
Yes, there can be. So sometimes there are so many valves in the market. There are Chinese valves, there are the US valves, there are the Indian valves. There's so many valves. So the frame and all what we see is from outside. We don't open it and check it. So there will be some variations where the anatomy will be different for each patient. So most of the times in 48 to 72 hours, if any complications comes, it will come. Once the valve is fixed, we make sure we diagnose and we do some diagnostic tests and check whether the valve is sitting there properly, if the gradient is fine, or if there are any paravalvular leaks. If we have a doubt, we do a transesophageal echo, or we take them to the cath lab and do a fluoroscopy and see whether if it's properly aligned or not, whether if it's in place or not, because we are not stitching anything anywhere, we are just fixing it there. So when we are fixing it, we always measure the areas. We do a CT tower protocols. We do TEs and all to confirm the size, and then we order the size and we get it and we'll do it.
So
So
it's gonna be a fixed size. We have options in
we
it
have a lot
too.
of options. Yeah.
Okay. So what are this valve? I mean, like, what material are they made of?
So the frame is a ninetol frame. So some places in some companies they change, but the valve inside it's tissue.
So
It's
do they
a
cause
it's a
any
pericardium tissue.
compatibility issues with the body tissue?
And, generally no.
Not even a 1% case wherein they
Uh,
develop that resistance or like,
yeah, we never saw till now
okay.
anyone who developed any resistance because everything is treated. So before when they are manufacturing, when it's being coming into the box and coming to the patient, it's been treated. So it will be in a solution where there won't, and directly we place inside the heart, so it's not exposed anywhere outside, and there shouldn't be any reaction to the valves.
So once if they get this valvular procedures done, how often are they asked to see the cardiologist again? Are they like allowed to live a normal life?
Yeah, definitely. So initially, because of the punctures and the like access sites, we ask them to restrict themselves for a couple of days. Normally, we ask them to do all the routines. Within a week, they'll be very much active to do everything. We ask them to come and see like initially like 15 days, 1 month, because there will be some BP fluctuations, heart rate fluctuations, and then once in 3 months and once in 6 months we check, and if everything is fine, we check once in a year.
So apart from this, are there any other minimally invasive procedures which can like contribute to the management of heart attacks?
Yeah, heart attacks. See, if you talk about heart attack, it's an acute emergency situations. So we won't have time to use so many intervention methods in that. That's why we ask them to have a checkup before. If we diagnose something, some calcified stenosis or some fibrotic lesions, where when a patient comes with a heart attack, it's very hard to deal with it. So you can't use any methods like orbital atherectomy, some drilling machine, some calcified block modification methods and all. So that time we can't use this. So that's the back. If a patient comes with heart attack, the main motive will be to save him, to get out of the hospital first. So that's why we have so many methods, but it's we say like time is muscle, especially for the heart. If it's damaged, it won't come back again. So that's why we want to do it as quickly as possible.
So, in your expertise, in your experience till date, like you must have seen youngsters also going through this cardiac issue. So, what are your views on it?
So youngsters, especially, I see a lot of youngsters. Generally, their heart doesn't tolerate. Okay, people thinks okay, older people, because their age is high.
I
So
feel older people are way better in handling these things than
yes, I
youngsters.
mean, like, see, when we age, our body gets adjusted.
Yeah.
Our collaterals opens up in the heart. So even if one side, if it's being blocked, there will be a collateral supplying from the other side. That happens after a certain age, and if it's a normal aging process like atherosclerosis and all. If you talk about young patients, it's not a normal atherosclerotic process. It's a quick, sudden things. So heart doesn't tolerate, the muscle gets damaged very quickly. So that's why we say, like, if you have any discomfort, immediately go get an ECG done at least. I'm not saying 100% ECG will show something, but at least an ECG will
That
have
irregularity can be
something,
addressed.
some little bit of variation. Or if the doctor can suspect, like, okay, this looks like some cardiac issues. We see a lot of patients, not every heart attack patients will have ECG changes.
Oh.
Sometimes we see patients, if they have recently, like a couple of days back, one woman came, female, she was having severe pain, but ECG doesn't have any changes, but the pain looks like classic angina. So I took her to the cath lab, and there's an artery which is dominant artery, 100% occluded. So it's yet to transfer to the ECG. So there will be some time
Delays.
delay will be there. So you shouldn't neglect any sort of
So, you mean to
discomfort.
say it's not, I mean, we aren't allowed to rely on ECG completely?
Yeah, not.
How
If
about
you have classic symptoms, then
like?
it's like angina, chest discomfort, radiating, palpitations, sweating, and exertional symptoms or breathing difficulty. At least an observation wouldn't cause any harm.
Okay. So, any other diagnostics apart from ECG?
So ECG, HS troponin I is a biomarker. So it will, if ECG is normal, echo is normal. If there is some minimal damage in the heart muscle, these biomarkers will be elevated. It's a sensitive marker. If there are infections and all, it may elevate also. But still, we see it any like gradual rise in the troponin I values. Then we say this is related to the heart attack. We better check, do an angiogram and check. Not all the time it will be true, but 95% it will be true.
So, coming to the stenting part, are there any cases where the stents backfired?
Backfire in the sense, there is nothing like backfire, but the anatomy, as we are talking about the anatomy, every individual's anatomy is different. People thinks like he has one stunt, he has two stunts. There are so many things behind that. So the lesion may be soft, the lesion may be hard, the lesion may be tortuous, the lesion may be calcified, the lesion may be fibrotic. So all these things might be there, or it can be a simple one. So people doesn't know like whether how hard it is. So there are diagnostic tools, as I was telling. There is OCT, IVUS, this cameras where we can put inside the coronary arteries and check the morphology of the lesion. Then we can decide and use the newer
I'm
methods.
just curious to see how the camera looks like.
Is like, you can say, like it's a small LED light, right?
The
The
size of-
minute, yeah, it's just an LED.
Okay.
It's an infrared ray. So if you put it in a very small size tube,
Okay.
so the reflection, you understand, right? So
Yeah,
the
I get
infrared
that.
rays which reflects towards it will be calculated, and that will be seen in the machine. It will be it will be coming on a screen.
Okay.
So based on the density, based on the morphology, we can see whether if it's calcified, whether if there is a plaque, whether
Is
there
this
is
a
a
painful
clot.
procedure?
It's not. It's not. It's a
Okay.
simple procedure. The same time, it comes with a cost.
So all these interventional procedures, are they done under GA or LA?
No, it's just under the local anesthesia. No GA.
Okay, no GA.
No GA. Only sometimes in a longer procedures like transcatheter structural heart disease, like mitral clip. Mostly for mitral clip, we give general anesthesia, and most of the other procedures we do under local anesthesia.
So there are certain patients who are initially noticing some cardiac signs and symptoms, and then when they get to see the doctor, and when the doctor asks them to get certain investigations done, they go into a panic mode. So they'll hold that tremendous anxiety and all. Will that have any impact on the current situation of that so-called person?
Anxiety, most of the
Can
people,
that aggravate that cardiac issue?
generally not.
Okay.
So when we suggest some patients to go undergo CT coronary angiogram, so they panic.
Yeah, they do.
Yeah. So when you go into the machine, they panic. So their heart rate increases. So there will be some variation in the images.
I mean to say, in such cases, as a current condition, are there any chances that can get worsened?
The condition it doesn't worsen. Only thing is the visibility of the lesions or the clarity will be varied if the heart rate is high. The patient gets like panic attacks, and they have this BP fluctuations, and sometimes they have this vasovagal syncope, they get giddiness and fall. So all these things may happen. So we always want them to do in a contained closed environment where doctors or nurses or the good technicians are available right then there to treat if anything happens.
So, in certain families, there are congenital histories of cardiac issues and all. In such cases, like young generations are, they really want to be like quite aware of what exactly they're going to come across in future. So they want to be little cautious about that. In such cases, are there any investigations where they can rule out the future consequences based on the congenital factors?
Yeah, definitely. It's a very good question. So I'm also interested so much in this preventive cardiology. So now a lot of people are talking about longevity. So
Yeah.
if you think of longevity, so cardiac longevity is one thing which we need to focus on. So the if you talk about preventive cardiology, so there are a lot of investigations and even genetic studies I started doing for most of my patients, in younger patients, to see if they have any genetic preponderance to have a cardiac disease. Cardiac disease, not only heart attacks, there are cardiomyopathies, there are channelopathies, there is multiple things where we can diagnose with genetic studies. And we have this new modalities like a CT scan or the risk assessment like ultrasound, carotid for plaque estimation, femorals for plaque estimation, coronary calcium scoring. So all these are risk factor assessment things. Now lipoprotein A we can check, blood test we
So
can
there is
do.
a possibility for
Yeah, there is a
pre-assessment.
possibility to have a prior diagnosis and pre-assessment.
To
Uh,
what extent?
what extent, in the sense, it depends on every individual. So we can't like generalize everyone in this picture, especially when younger individuals, if their parents or grandparents, if they have an early heart attacks or early heart diseases, or if they're suffering with any cardiomyopathies, heart failures, heart diseases, channelopathies. So those people can at least have an little bit of analysis regarding this, and they can diagnose priorly and have a better treatment so that they don't fall under these conditions.
Nice. At least these younger generations are pretty privileged enough to have those pre-assessments and then work on it.
Definitely, now it's a boon to have all these interventions and all this technology, which is very handy to us.
Basically, the lifestyle, the diet, and the stress management, I can say, we fail at every tiny thing which contributes to a healthy life, right?
Yeah.
All these are much needed.
So recent past, we are telling like all the corporates, they come in for checkups, and we see a lot of hypertensions.
Yeah.
We say white coat
Unavoidable.
hypertensions, palpitations, high heart rates. They come very often. So we always try. We can give a medicine. It doesn't work for a long time, and we always keep on increasing the medicines and all. But other way around, the lifestyle management is very important for these patients. Some physical activity, some exercises, some concentration, some focus, some meditation, everything helps for at least physiologically,
At least to certain
to
extent.
yeah, to certain extent. So that's why when people comes, when we do some checkups, uh, like we do in corporates, we do like people, the runner associations will be there, and the communities will be there. We always go and do some checkups there and try to check
Like,
BP and basic ECGs at least,
okay.
not all the tests. So we do diagnosis. There are
It's a
a lot
kind
of
of educating them
a
too.
lot of underdiagnosis is there in our community. No one likes to come to the hospital, or they will feel some
See,
people.
it's not that they don't want, it's just the fear of it.
Yeah, at least you have clinics, you have diagnostic
Most
centers.
of the people hold that fear of, see, no matter what they're going through, when they get to see the person who's sitting next to them suffering, they just hold that fear. Oh my God, something is going wrong. What else could go wrong with me? Isn't it?
But your life is important too.
True.
Yeah, so when you are so focused on your life, you want to live longer and do something for
Yeah.
yourself. Your health is also an important thing. So
Well,
most of the
nice.
peoples you can see, they don't focus on their health. Health is a completely different thing.
Until and unless there are some strong alarming signs, they don't get to
That's
keep the gym or diet or
that's
sleep
the
or
thing.
whatsoever
That's the
it
thing I'm
is.
saying. Like alarming sign, you don't want to see that alarming signs. That's what. Like now in India especially, I see a lot of people from abroad, from US, Canada, UK, everywhere. They come every year for checkups. They come every year for checkups, at least alternative years. If anything is there, they get treated and they go, because all those things are not being done there. They don't do checkups on a regular basis.
So, as we were talking about the lifestyle, diet, and a few stuff, so do you think this obesity will contribute to the cardiac health?
Yeah, obesity is a main risk factor. It's not that all obese people will have a cardiac issues, but if you take as a bulk out of 100, there will be a lot of higher fluctuations where they can have this cardiac disease. It's not directly correlated, but they can have diabetes, dyslipidemia, high uric acid, renal issues, hypertension. So all these things are major risk factors for the
But
heart
still,
disease.
apart from obesity, there are certain lean people also who've been through cardiac issues. In that case,
Yeah, that's like a myth. It's not, that's what I'm saying. It's not that obesity is directly proportionate to the heart disease. Even lean people, even fit people, even like the best
I
of the
want
best.
I want you to make it a clear statement to the viewers, because there are many people who hold that myth that fat people, obese people, they'll only have to go through all these cardiac issues, and the lean people are always safe.
Nothing like that. Lean people, if you go to a hospital and see how many obese people are getting treated for the heart disease, how many lean people are
Yeah,
getting
true.
treated, there are more lean people than obese people
Oh, really?
nowadays. Yeah. So that all the young people, they go to gym, they do diet, they do exercise and all. They always come and ask, why do I have a heart disease? So you can have a genetic preponderance, your stress levels may be high. So there are so many factors for your atherosclerosis. People thinks that blocks start only after certain age, maybe after 40 years, 50 years.
Yeah.
Yeah.
Most of them
Yeah,
think like that.
like our atherosclerosis starts when we are 2 years age.
Oh.
So this atherosclerosis, this depositions and all, it starts from 2 years. So the aging, if we are fit, if everything, it starts increasing maybe somewhere around 50s and 60s, and we see at 70s if they are preponderance is there, or if the risk factors are there, it starts early. If genetic factors are there, it starts early. If stress is there, even if it's like, if you talk about smoking, so smoking, people comes and says my arteries are normal, I smoke, so even if it's
But a
normal,
lot
right?
a lot happens inside
Yeah,
already.
that's what, like even nicotine is one bad thing. It's an enemy for the vessels.
Oh.
So even if you don't have any block, it can block the arteries. Nicotine itself can cause thrombus, clots. So 30-40% blocks, people will think, I can smoke, and but I say no. Even 30-40% blocks, you are still more prone to have blocks, clots, if you still take nicotine.
More or less, these cardiac issues are like pretty unpredictable. Everything is in our hands. We can assume that it's in our hands, but not really. isn't it?
Not that everyone should think the same, but yes, it's not in our hands. But whatever is in your hands, you
To
can do
certain
it.
extent.
Certain extent. At least you can have an assessment once in a while. I'm not saying come
Yeah.
every month or come every 6 months or come every year. If you have risk factors, then definitely every year. If
Better
you
to have a regular checkup.
yeah
Nothing wrong.
yeah, nothing wrong. It's you go for trips, you go for vacation, you do a lot of things. In any year you want to do these things, and you put a schedule and you have a calendar. Why
Likewise.
not why not
Why
a
not?
checkup? Now you have a diagnostic centers everywhere. You can see big diagnostic centers,
Yeah.
nursing homes where they have all the diagnostic things. It's like a 5-star facility. You can just go, have they're giving you good breakfast. You can do some investigations and
Nice.
have some results, and even you can consult online. It's not that you have to wait for the doctor like forever. It's not like that. You can consult online, show your investigations, tell your problems, and you can have some diagnosis at least.
So, thank you so much, Dr. Ranga Reddy, for your valuable insights, your precious time, and then tremendous knowledge on all these cardiac issues. And looking forward to know many more in our coming episodes. Thank you so much.
Thank you very much.
Hi, hello everyone. Considering our routine, a daily routine, a lifestyle management, a diet, stress, whatnot, more or less we have our own queries, confusions, and a lot more considering our cardiac health and mental health and general health, right? So, to know more about your cardiac health, we have Dr. Ranga Reddy on our show to sort up all your doubts and queries. Thank you.